Hello, dear students. We continue our lectures. The topic of today's lecture is lymphoma and multiple myeloma. Let's start. The lymphomas are malignant disorders of lymphoid tissue subdivided into two broad groups, Hodgkin's lymphoma and non-Hodgkin's lymphoma. The lymphomas arise in lymph nodes or in other lymphoid tissue of the body. They are of widely different clinical presentation and clinical course ranging from indolent types, which may not need treatment for many years, if at all, to aggressive high-grade disease, which can, without appropriate treatment, cause death within a few weeks of presentation. The major subdivision of lymphomas is inter-Hodgkin's lymphoma and non-Hodgkin lymphoma, and this is based on the histological presence of red Sternberg cells in Hodgkin lymphoma. The non-Hodgkin lymphoma are further subdivided into B-cell diseases and T-cell diseases, and each of these groups contains many different types. Thomas Hodgkin, curator of the Anatomy Museum of Guy's Hospital in London, described the disease in 1832, following his account of affected lymph glands in post-mortem cases, titled on some morbid appearances of the absorbent glands and spleen. Dorothy Reed and Carl Sternberg were pathologists who identified the abnormal cell that defined this subtype of lymphoma in 1898. Interestingly, neither Sternberg nor Reed felt that this disorder responded a neoplasm. Sternberg believed that it was a variant of tuberculosis, whereas Reed felt it to be an independent entity of inflammatory origin. Hodgkin lymphoma is a potentially curable lymphoma with distinct histology, biologic behavior, and clinical characteristics. Young adults aged 20-40 years are most often affected. However, a second incidence peak is seen in individuals aged 55 and older. Slightly more men than women are diagnosed with Hodgkin lymphoma. Pathological diagnosis should be made according to the World Health Organization classification from a sufficiently large surgical specimen of excisional lymph node biopsy to provide enough material to fresh, frozen, and formalin mixed samples. Under the term Hodgkin lymphoma are recognized two clinically and biologically different entities. Classic Hodgkin lymphoma, of which there are 4 histological types, and non-classic Hodgkin lymphoma, which includes the entity of lymphocyte predominant Hodgkin lymphoma. The cause of Hodgkin's lymphoma remains unclear. It's not associated with exposure to radiation, chemicals agents working in healthcare-related professions, or previous tonsillectomy. The leading suspect remains Epstein-Barr virus, based on much suggestive evidence, but no definitive proof. Epstein-Barr virus is a large pre-lymphocyte tropic herpes virus. Approximately 90% of the general population occurs infection with Epstein-Barr virus by early adulthood. Antibodies to the viral capsid antigen reach higher levels in patients with Hodgkin's lymphoma than in controls. And these higher levels appear several years before the neoplasm. Hodgkin red Sternberg cells is approximately 50% of cases of Hodgkin's lymphoma contain Epstein-Barr virus encoded small RNA circumstantial evidence for genetic contribution to the etiology of Hodgkin's lymphoma comes from studies showing that Hodgkin's lymphoma is almost 100-fold more likely to develop in the monozygotic twin of an affected individual than in a dizygotic twin. First-degree relatives of individuals with the disease have up to a 5-fold increased risk for development of the lymphoma. Hodgkin's lymphoma is usually manifested as lymphadenopathy, typically in the cervical, axillary, and mediastinal areas, and only about 10% of the time as nodal disease below the diaphragm. Approximately 25-30% of patients with Hodgkin's lymphoma have constitutional symptoms. The classic symptoms, significant weight loss, night sweats, and persistent fever, usually signal widespread of locally extensive disease and imply a need for systemic treatment. Generalized pruritus, occasionally severe, can antedate the diagnosis of Hodgkin's lymphoma by up to several years. Some patients have symptoms suggestive of a growing mass lesion, such as cough or stridor, as a result of tracheobronchial compression from mediastinal disease or bone pain secondary to metastatic involvement. Because Hodgkin's lymphoma can involve the bone marrow extensively, and occasional patients has symptomatic anemia or incidentally node pancytopenia. Paraneoplastic neurologic or endocrine syndromes are rare. Peripherally located nodes seldom reach large size. Very large mediastinal masses or less often retroperitoneal masses can develop with only modest symptoms. Lymph node involvement in Hodgkin's lymphoma is usually painless, but an occasional patient note discomfort in involved nodal sites immediately after drinking alcohol. Mediastinal lymph nodes involvement may be associated with pleural effusions or superior vena cava obstruction. Costford modification of the N-Erber staging system categorizes patients into 4 stages. The first 3 indicate the expanding extent of lymph node disease. Stage 1, a single nodal area. Stage 2, 2 or more nodal areas, but still on one side on the diaphragm. And stage 3, nodal disease on both sides of the diaphragm. The spleen and the lymphoid tissue is Walter's ring, each count as nodal sites in this system. Stage 4 is reserved for extranodal disease, which for all practical purposes is disease in the bone marrow, lung, bone, or liver. Hodgkin's lymphoma and any other extranodal site should prompt questioning of the diagnosis or a search for HIV infection. The stage number in all causes is followed by the letter A or B indicating the absence or presence of one or more of the following. Unexplained fever above 38 grams, night sweats, or loss on more than 10% of body weight within 6 months. Localized extranodal extension from MS of nodes does not advance the stage, but is indicated by the subscribe E. Thus, mediastinal disease with contiguous spread to the lung of spinal decavult, they are classified as IE. As involvement of the spleen is often a prelude to widespread hematogous spread of the disease, patients with lymph node and splenic involvement are staged as 3S. Bulky disease is relevant to therapy at any stage. Diagnostic Reed-Steinberg cells are large cells in diameter or more with evident weakly acidophilic or amphiphilic cytoplasm, which may appear homogeneous or granular and lacks a pale zone in the Golgi area. The nucleus is pilobed or polylobed. The nuclear membrane is thick and sharply defined. The nuclear pattern is usually vesicular, but with some coarse chromatin clumps scattered through. There is very large, variously shaped, but usually rounded, highly acidophilic central inclusion like nucleus surrounded by a clear halo. When the two lobes face each other, all eye appearance results. Cells with this set of features but lacking nuclear lobation are referred to as mononuclear variant of RS cells or H cells. Nodular sclerosis is the commonest histological subtype and is characterized by bands of fibrosis that enclose nodules of lymphoid tissue containing variable numbers of Hodgkin cells. The disease affects primarily young adults and is less often observed in the elderly. This subtype is distinguished by the presence of collagenous bands that divide the lymph node into nodules, which often contain enriched Steinberg cells variant called the lacunar cell. Some pathologists subdivide nodular sclerosis into two subgroups on the basis of the number of Reed-Steinberg cells present. Transforming growth factor beta may be responsible for the fibrosis in the nodular sclerosis Hodgkin lymphoma subtype. Mixed cellulite Hodgkin lymphoma is more common in young children than in adolescents and adults. Mixed cellulite Hodgkin lymphoma is characterized by the presence of a heterogeneous mixture of lymphocytes, eosinophils, neutrophils, plasma cells, epithelial cells, and Hodgkin cells. Reed-Steinberg cells are frequent in a background of evident normal reactive cells, lymphocytes, plasma cells, eosinophils, and histiocytes. Interleukin 5 may be responsible for the eosinophilia in mixed cellularity Hodgkin lymphoma. This subtype can be confused with non-Hodgkin lymphoma. Lymphocyte-depleted Hodgkin lymphoma is a rare form and is characterized by a low number of lymphocytes, by the absence of fibrosis bands, and by numerous, sometimes anaplastic Hodgkin's Reed-Steinberg cells. Lymphocyte-rich classical Hodgkin lymphoma may have a nodular appearance, but immunophenotypic analysis allows distinction between this form of Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. The pattern in LDHL is diffuse and often appears hypercellular due to the presence of fibrosis, necrosis, and paucity of inflammatory cells. Large number of classical RS cells are present with their pleomorphic sarcomatous variants. Approximately 70% of patients present at an advanced stage, and most have B symptoms. Lymphocyte-depleted Hodgkin lymphoma is rare in children. Is it common in adult patients with human immunodeficiency virus? This subtype is characterized by the presence of numerous large, with their malignant cells, many Reed-Steinberg cells, and few lymphocytes. Diffuse fibrosis and necrosis are common. Many cases previously diagnosed as lymphocyte-depleted Hodgkin lymphoma are now recognized is diffuse large B-cell lymphoma, anaplastic large cell lymphoma, or nodular sclerosis, classical Hodgkin lymphoma with lymphocyte depletion. The diagnosis of Hodgkin's lymphoma is primarily based on the recognition of the typical tumor cells, either HRS cells or LP cells in the appropriate environment. The immunophenotype of the neoplastic cells in Hodgkin's lymphoma can help identify the specific subtype. Typically, the Hodgkin Reed-Steinberg cells stain positively for CD30. However, often only a minority of the malignant cells stain positively for the CD15 and PSAP markers. Nodular lymphocyte predominant Hodgkin's lymphoma almost always stains strongly positive for CD20. Lymphocyte-rich classical Hodgkin lymphoma cells express CD15 and CD30, while nodular lymphocyte predominant Hodgkin lymphoma almost never express CD15. T-cell-rich B cell lymphoma can be very difficult to distinguish for nodular lymphocyte predominant Hodgkin's lymphoma because both are negative for CD30 and CD50, but positive for CD45. Comparison between two types. Classical type, it's most part of patients with Hodgkin lymphoma. In this case, can be found only Reed-Steinberg cell. However, nodular lymphocyte predominant type is more rare, and so-called popcorn cells is unique to this kind of Hodgkin lymphoma. These patients have a very good prognosis, but disease can replace later 10 years after and require another course of treatment. Replace disease treatment. 10 to 30% of patients experience replace. Careful attention should be directed to lymph node sites, especially if previously involved with disease and not treated with radiation. New persistent focal symptoms such as bone pain should be investigated with appropriate laboratory and imaging studies. A dose of 4,000 radiation is used, and high voltage radiotherapy techniques allow the treatment of all lymph node areas above or below the diaphragm by single upper mantle or inverted Y blocks. Radiotherapy also has a role in the treatment of bulky tumor masses, such as mediastinal tumor that remains after chemotherapy or painful skeletal, nodal, or soft tissue deposits. Outcomes of Hodgkin lymphoma. In assessing the long-term 20-year results of treatment, it has been established. During the first 5-8 years after the end of treatment, the patients mostly die from Hodgkin's disease progression. After 15-20 years of follow, leading cause of death of patients are late complications of treatment, secondary tumors and leukemias, myocardial infection, serious damage to the lung tissue after mediastinal irradiation, particularly when combined with bleomycin. The World Health Organization classification divides lymphomas on the basis of B cell or T cell origin and whether they are derived from primitive precursor cells or from more mature peripheral cells. Specific clinical and pathological entities are recognized within each of these groupings. B-cell lymphomas make up most of non-Hodgkin's lymphomas. Non-Hodgkin's lymphoma is a heterogeneous group of lymphoproliferative malignancies. More than 30 different subtypes of non-Hodgkin's lymphoma has been identified and categorized according to several prognosis factors, including size, growth rate, and anatomic site. In 1956, Rappaport prognosed a lymphoma classification that was based on the pattern of cell growth and size and shape of the tumor cells. Classifying non-Hodgkin's lymphoma can be quite confusing because there are so many types and because several different systems have been used. The most recent system is the World Health Organization classification. The whole system groups lymphomas based on how they look under a microscope, the chromosome feature of the lymphoma cells, and the presence of certain protein on the surface of the cell. Aggressive non-Hodgkin's lymphoma. Short natural history, disease of repeat cellular proliferation, potentially curable with chemotherapy. Indolent non-Hodgkin's lymphoma, long natural history disease of slow cellular accumulation, generally curable with chemotherapy. Non-Hodgkin's lymphoma working classification includes low-grade small lymphocytic, follicular small cleaved cell, follicular mixed small cleaved and large cell, intermediate grade follicular large cell, diffuse small cell, diffuse mixed small and large cell, diffuse large cell, and high grade large cell, immunoblastic, lymphoblastic small non-cleaved cell. After diagnosis, a meticulous staging evaluation is necessary to estimate prognosis and determine therapy. Staging requires a careful history and physical examination, complete blood count, renal and hepatic function tests, serum lactate, dehydrogenase level, computer tomography of the chest, abdomen and pelvis, and bone marrow biopsy. Positron emission tomography can be helpful to identify initial sites of involvement and after treatment to distinguish persistent lymphoma from residual fibrosis in methicene on computer tomography. The most common staging system is an Erber classification. In addition, each stage is subdivided into A and B categories. A wide variety of patient factors and tumor factors can affect treatment outcomes. The International Prognostic Index is the most widely used method to predict treatment outcome and survival. The IPI is based on 5 adverse factors: age older than 60 years, performance status less than 2, elevated serum LDH level, 2 or more extranodal sites of disease, and Arbor stage 3 or 4, which are summed to give the score. Follicular lymphoma most commonly presents as a painless, slowly progressive adenopathy. Systemic symptoms such as fever, night sweats, weight loss is in excess of 10%, or asthenia are infrequent at presentation, but can be observed in later stage of the disease. Progressive to an intermediate grade or higher grade lymphoma should be considered when a patient develops systemic symptoms. The spleen and bone marrow are often involved, and the patient may present with a primary skin or small intestinal tumor. Symptoms related to bone marrow dysfunction, such as anemia, leukopenia, or thrombocytopenia, are rare at presentation. Peripheral T-cell lymphomas are neoplasms or post-thymic T cells. These include relatively indolent disorders such as mycosis, pangoids and CD30 plus cutaneous lymphoproliferative disorders, but most patients diagnosed with peripheral T-cell lymphoma have an aggressive neoplasm. Peripheral T-cell lymphomas represent only 15% of the non-Hodgkin's lymphomas. For the initial treatment of patients with intermediate or high-grade lymphoma and patients with bulky disease, and inpatient setting is recommended in order to monitor for tumor lysis syndrome and to manage appropriately. Follicular lymphoma comprises 70% of this group. Indolent stage 1 and contiguous stage 2 non-Hodgkin's lymphoma. Standard management consists of radiotherapy alone. 40% of patients with limited stage disease remained disease-free at 10 years after radiation. Unreasonable in selected patients with stage 1-2 non-Hodgkin's lymphoma who have inferable prognostic factors, B symptoms more than 2 nodal sites. The disease course of indolent lymphomas is characterized by a continuous decrease in the quality and the duration of response with each subsequent treatment or treatments due to the existence of chemotherapy resistance, rituximab, a monoclonal antibody targeting CD20 antigen present in benign and malignant B cells. In combination with systemic chemotherapy, the treatment of symptomatic patients with indolent lymphomas should be focused on achieving the best possible quality of response without producing excessive toxicity. Single agent is useful in elderly patients with significant comorbidities. Combination chemotherapies are used in younger patients with the goal of achieving a complete remission. The preferred treatment option for patients with intermediate grade non-Hodgkin's lymphoma is combination chemotherapy plus involved field radiation therapy. Rituximab with standard doses of CHOP chemotherapy should be considered for elderly patients with diffuse large B-cell lymphoma. Autologic and allogenic bone marrow of peripheral stem cell transplantation following chemotherapy for patients at high risk of relapse. Treatment of acute lymphoblastic lymphoma, a very aggressive form of non-Hodgkin's lymphoma, is usually patterned after acute lymphoblastic leukemia therapy. High-dose chemotherapy plus stem cell transplantation is the treatment of choice for patients who have recurrent aggressive lymphomas. Second-line chemotherapy regimens such as ICE, DHAP, or EPOCH are usually used with rituximab if the tumor is CD20 positive. Patients who are not candidates for transplantation can be treated with chemotherapy with or without monoclonal antibodies. The treatment of T-cell lymphomas continues to be challenging. Typically, cutaneous T-cell lymphomas are managed with topical agents and oral disease modifiers during the early stage of the disease. Surgery is useful in selected situations, particularly if the disease is located, if the risk of perforation, obstruction, and massive bleeding is present. Hodgkin lymphoma generally involves contiguous nodes. Non-Hodgkin lymphoma is non-contiguous. Multiple myeloma is a plasma cell malignancy in which monoclonal plasma cells proliferate in bone marrow, resulting in over evidence of monoclonal paraprotein, destruction of bone, and displacement of other hematopoietic cell lines. First described in 1848, multiple myeloma is part of a spectrum of diseases ranging for monoclonal grammopathy of unknown significance to plasma cell leukemia. Multiple myeloma accounts for 10% of all hematologic cancers. It is a heterogeneous disease with survival ranging for 1 year to more than 10 years. Etiology. The precise etiology of multiple myeloma has not yet been established. Roles have been suggested for a variety of factors, including genetic causes, environmental or occupational causes, radiation, chronic inflammation, and infection. Genetic causes. Multiple myeloma has been reported in 2 or more first-degree relatives and in identical twins. Also, no evidence suggests hereditary basis for the disease. Environmental or occupation causes. Case-controlled studies have suggested a significant risk of developing multiple myeloma in individuals with significant occupational exposures in the agriculture, food, and petrochemical industries. And increased risk has been reported in farmers, especially in those who use herbicides and insecticides, and in people exposed to benzene and other organic solvents. Smoldering multiple myeloma. Monoclonal gammopathy of undetermined significance is defined by the presence of 3 criteria: serum monoclonal M protein concentration less than 3 gram deciliter, bone marrow plasma cell concentration, no evidence of end organ damage. Signs and symptoms. Presenting signs and symptoms of multiple myeloma include bone pain, pathologic fractures, weakness, anemia, infection, hypercalcemia, spinal cord compression, and renal failure. In approximately 13% of cases, multiple myeloma is discovered through routine blood screening when patients are being evaluated for unrelated problems. In 1/3 of patients, multiple myeloma is diagnosed after a pathological fracture occurs. Such fractures commonly involve the axial skeleton. 2/3 of patients complain of bone pain commonly with lower back pain. This bone pain is frequently located in the back, long bones, skull, and or pelvis. Bone pain is the most common presenting symptoms in multiple myeloma. Most case series report then 17% of patients have bone pain at presentation. So, lumbar spine is one of the most common sites of pain. The symptoms that should alert physicians to consider spinal cord compression are back pain, weakness, numbness, or disaster in the extremities. Occasionally, a patient may come to medical attention for bleeding resulting from thrombocytopenia. Rarely, monoclonal protein may absorb closing factors and lead to bleeding. Confusion, somnolence, bone pain, constipation, nausea, and thirst are the presenting symptoms of hypercalcemia. Abnormal humoral immunity and leukopenia may lead to infection. Pneumococcal organisms are commonly involved. Viscosity may be associated with a number of symptoms, including generalized malaise, infection, fever, paresthesia, sluggish mentation, and sensory loss. Patient may report headaches and somnolence, and they may bruise easily and have hazy vision. Physicians must understand both the natural history of multiple myeloma and the limitation of current therapy in the treatment of the disease. The objective in therapy is to obtain the deepest response in the first round by choosing the appropriate regimen. This should lead to better overall survival in both transplanted and non-transplanted patients. Also, multiple myeloma remains incurable. Several drug therapies are available in the treatment of patients with multiple myeloma, as are autologous stem cell transplantation, radiation, and surgical care in certain cases. For primary induction therapy in patients with multiple myeloma who are candidates for transplantation, NCCN guidelines recommended the following combinations as preferred regimes. Bortezomib, lenalidomide, dexamethasone, and bortezomib, cyclophosphamide, dexamethasone. Other recommended regimes according to the NCCN are as follows. Carfilzomib, lenalidomide, dexamethasone, or ixazomib, lenalidomide, and dexamethasone. The NCCN considers the following regimens are useful in certain circumstances. Bortezomib, doxorubicin, dexamethasone, carfilzomib, cyclophosphamide, dexamethasone, ixazomib, cyclophosphamide, dexamethasone, etc. Patients should be assessed for response after 2 cycles of one of the above regimes. Patients with multiple myeloma who are treated with lenalidomide or thalidomide are at significantly increased risk for thrombotic events, and many physicians incorporate anticoagulating staging in their management. As monotherapy is in combination interferon alpha 2b and prednisone modestly prolong the disease-free interval. Adjunctive therapy for multiple myeloma includes radiation therapy to target areas of pain, impending pathology fractures, or existing pathologic fracture. Adjunctive therapy may also include any of the following as appropriate: erythropoietin, corticosteroids, plasma pheresis, surgical intervention. Thank you for your attention. Goodbye.